All right, we're going to get started. Hi, everyone. Thank you all so much for joining us for the Project CASK Epilepsy webinar with our partners, Dr. Shahid and Oksana at New York Presbyterian Hospital. My name is Allie. I am on the leadership team and board of directors of Project CASK. I have a 5.5-year-old son, Graham, who has a CASK gene mutation, and he has had epilepsy. He was diagnosed about 4 years ago. Joining me from Project CASK is Alexis Taylor. She is also on the leadership team and board of directors, and she has a 10-year-old daughter, Piper, who has epilepsy and a CASK gene mutation. We are really happy that you guys are here. We know that this is a very important and meaningful topic to the community. For those of you that might not know, epilepsy is one of the most common comorbidities of CASK gene mutations. About 40 to 50% of our population experience seizures. So we know that this is meaningful to the community, and we are extremely grateful to Dr. Shahid and Oksana for taking this project on and looking into epilepsy and CASK in more detail and in more depth. So Dr. Shahid, he is an attending neurologist and epileptologist at New York Presbyterian Hospital. And Oksana Nulman is a research coordinator also at New York Presbyterian Hospital. So how today is going to go, I'm going to hand it over to Dr. Shahid in just one moment. He will do a presentation on rare epilepsies. Oksana will then provide some information about the upcoming epilepsy study that we are about to launch. And then at the end, we will have a Q&A session. If you have any questions about either rare epilepsies for Dr. Shahid or the study for Oksana and Dr. Shahid, feel free to just put them in the chat, and then we will make sure that we get to them. So without further ado, I'm going to hand it over to Dr. Shahid.
Okay, perfect. Sorry, I was trying to unmute myself. Thank you very much for the introduction, and really excited to talk to everyone. Let me put my slides up here. I think you should be able to see my slides, correct? Let me put this in presentation mode. So once again, thank you for the invitation to talk to you about this very important subject, especially as it relates to CASK and other DEEs, basically developmental epileptic encephalopathies. So what we thought we would do is, since there's no real data on what we're going to do in patients with CASK, we would use some other examples, some other DEEs, to see what was done in those developmental epileptic encephalopathies, and if we can apply sort of same thing to individuals with CASK and epilepsy. So just a quick introduction. Let's put this thing up. Okay. So just an overview, just quickly talking about what are biomarkers, because that's something that will come up multiple times, and that's something we'll be looking at in this study, and the importance of early detection in developmental epileptic encephalopathies. And we'll use the example of tuberous sclerosis and infantile spasms or West syndrome. And then we can talk about what the biomarkers would do and the role of biomarkers in improving diagnosis and treatment. So just a quick little introduction. In neurology, just like any field of medicine, right? So the assessments often involve multiple different evaluations, image-based. We use MRIs, we use CAT scans, we use other things like nerve conduction studies. We'll look at auditory, visual, sensory. So basically the whole thing. And EEG is such an important part of epilepsy evaluation, or just neurological evaluation. Doesn't have to be epilepsy. There are a lot of things that we can use the EEG for, encephalopathies, not necessarily epileptic encephalopathy, and looking at structural defects and a whole bunch of other things. And we also have to look at the history and the role of genetic testing, because those are very important. At what age something started, when it got worse, when it got better, or what it looked like in the beginning and how it changed. And of course, genetic testing, with more and more genes being identified, pathogenic genes being identified, that plays a really important role in what we do and what we look at. So what are biomarkers? So biomarkers, these biological molecules that indicate normal or abnormal processes. Or if you think about it, taking it at a sort of a macroscopic level, conditions or diseases. So we can use biomarkers for diagnosis, prognosis, and monitoring treatment responses. And as we will see in a little bit, how we can use those things for treatment response and for prognosis and just figuring out what the person might have. So there are many different types of biomarkers. Genetic, basically doing a genetic test and see what kind of mutation someone might have. Proteomic, which is basically the study of proteins. So because everything is protein, right? So when a gene forms its product or DNA at the end makes RNA and RNA makes protein, we see if the protein is the correct protein for the purpose or is it a more of a deformed protein that's not really doing what it's supposed to do. And that's a problem in majority of the cases. Then we look at metabolic markers and imaging, and again, EEG being one of those. So the purpose of this study, the CASK study, is going to be to basically try to identify biomarkers for early recognition of patients who are prone to developing epilepsy. So how would that help us? Well, it can help with early diagnosis of epilepsy. If someone is going to develop epilepsy, but they have not yet had their first seizure, can we identify those patients before they have their first seizure and say, okay, this person, because of these 4 or 5 things, is likely to have seizures. Can we do anything about those seizures before they actually start? And can we start treatment early on for something like that? And if you're going to start treatment, what is the right medication? Is there a right medication for this kind of epilepsy or this kind of seizure disorder versus something that we should avoid for whatever reason? And then, of course, we have to look at the assessment and we have to assess the cognition and developmental outcomes as we continue to monitor the children in a longitudinal manner. So this is sort of a diagram which is showing the main biomarkers that we use. So up here, we have the macroscopic, basically stuff that we can see. And then at the bottom, it's microscopic, obviously stuff that we cannot see. And what you see is basically you have genetic, RNA, CSF is cerebrospinal fluid, plasma, PET, and over here is different types of MRIs, different types of imaging studies. And then you have this huge gap, if you see, between the macroscopic and the microscopic, which basically is kind of, to some degree, filled by EEG. So EEG is an important biomarker for us because it can really make the connection between the microscopic and the macroscopic. So our hope is, again, when we do the study in class, that we can bridge the microscopic and the macroscopic together and sort of find out what's missing and how we can find out that missing stuff. In addition, we will also look at the MRIs because that's an essential part, and there's a big overlap between EEG and MRI. And of course, genetic, because in genetics, we could have many different types of mutations. I mean, in CASK itself, you could have missense mutation or you have nonsense mutation. So missense is where a protein is made at the end, but it's not the protein for the right kind of function. So that's where the problem arises. Or nonsense, where all of a sudden you are making a protein and everything stops. So the factory stops making the protein. So then we have to see between those 2 mutations or other mutations, which one would lead to epilepsy, which one may not, what does the MRI show, what does the EEG show, and then try to bring everything together and come up with a solid conclusion. So what else will we look at besides what I just talked about? Well, we're going to look at the age of diagnosis. Age of diagnosis of if you make the diagnosis of CASK, but more importantly, seizures. What age was the seizures diagnosed? Did the seizures start very early? Did the seizures start late? Because there are cases with late onset seizures. So what was the difference between the early onset and the late onset? Was there a difference in their biomarkers, their genetic mutation, their MRI, etc.? Other diagnoses, if any, right? So there could be other comorbidities that are not specific to what we see in CASK. The types of seizures, there are infantile spasms, There could be non-epileptic movements, or there could be other types of seizures. So we have to look at those. What medications were used to treat the seizures and how effective are they? And the assessments performed by the primary neurologist. What did they see as far as just longitudinal follow-up? Was there a worsening of seizures, cognition? Was there an improvement, perhaps, of both seizures and cognition? Or did anything else change? So I think those are all important things to look at. So biomarkers have been used in other conditions, like infantile spasms, which is basically a severe epileptic encephalopathy. Starts in the first year of life, mostly in the first 4 to 5 months of age. And it's characterized by these brief seizures we call epileptic spasms or infantile spasms. And these are associated with significant cognitive and developmental impairments if not controlled or identified early on in the course. If you can control those early, you can have a favorable outcome. But if they go on for months or years without really any positive response to medications, or if they were not identified early on, then you will have a more significant impact on the cognition and development. The other thing is, the other pathology is tuberous sclerosis complex, or TSC. So we'll talk about TSC in a little bit, in a little more detail. So it's a genetic disorder that leads to these benign tumors in multiple organs: brain, eye, skin, heart, lungs, kidneys. And it's also often also associated with epilepsy that starts early, again, in the first few months of life. So in tuberous sclerosis, we'll talk about the genetic disorder causing benign tumors in multiple organs and high prevalence of epilepsy, autism, and developmental delays are early on. And as I mentioned, we use genetic testing as biomarkers, and we know there are two genes that can have mutations, TSC1 and TSC2 on different chromosomes. And then in addition, we also look at other things like this mTOR or mammalian target of rapamycin pathway activity. Again, just bringing in all the information to first make a diagnosis and then see what the prognosis and treatments would look like. Looking at infantile spasms, again, as mentioned, it's severe epilepsy that starts in infancy. You can have developmental regression. There's a very specific pattern on EEG. So we look at that EEG and we can say, even if the child is not having seizures, we can look at that EEG and we can say, okay, this is an abnormal EEG. Even if the child is not having seizures, this is the type of seizures they may have, which would be, again, infantile spasms or epileptic spasms. And we look at ACT, ACTH, cortisol levels, and the specific EEG patterns. Now we can do genetic testing. There are certain pathologies or syndromes where you see higher rates of infantile spasms. For example, tuberous sclerosis. So or Down syndrome. So if I have a patient with Down syndrome or tuberous sclerosis, just looking at them and knowing what we know, again, from earlier studies, much earlier studies, I would start to keep an eye on them and see if they are going to develop spasms. So it's really important to, again, look at those biomarkers in tuberous sclerosis detection. So we look at the two mutations, TSC1 and TSC2, and then MRI and CT imaging for early identification of brain lesions. So believe it or not, sometimes these patients are even identified to have possible tuberous sclerosis in utero when they're still in the belly, and you do the prenatal ultrasound. Sometimes you can detect these cardiac tumors, and sometimes they can be large. So then you start to suspect, oh, maybe the baby who's still developing may have tuberous sclerosis. So imaging studies become extremely important in all of these. So the benefits are, improved prognosis with early intervention and personalized treatment strategies. So we can just bring those and employ them and follow the child, again, longitudinally. So the biomarkers for disease monitoring and treatment response in TSC, such as serum levels of certain chemicals that are being studied for their role in disease progression and response to treatment. So there are a lot of studies going on. They're looking at many different chemicals. And the more we know, the more questions there are to answer. So that's what we want to start with. We want to start with questions and see if we answer the questions or if we have more questions from that. And that happens in science a lot, right? So then we try to answer those questions. Genetic biomarkers remain crucial in TSC with mutations in the two genes that we mentioned. Those are the primary markers for diagnosis. And then you look at the utility of these genetic markers in predicting disease severity and treatment outcomes. I have seen patients with tuberous sclerosis, both who have severe forms of autism, severe forms of epilepsy, and I have seen children with tuberous sclerosis who go to normal schools, are doing really well in their cognitive domain and in their schools, and may have rare seizures. So you have this great big sort of a divide between the severities of the disease within the same syndrome. So there was a longitudinal study which was looking at biomarkers for impending infantile seizures or infantile spasms in TSC. This study was done, I think, a while ago now, maybe 20, 25 years ago. And what they did was they said, okay, we have identified a child with tuberous sclerosis. They have not had seizures yet, but can we predict if they're going to have seizures or not? So what they did was they started to do EEGs, even in children who had no seizures, and they started to find out that there were findings, even before the seizure started, that they could say, okay, this child is at risk for developing epilepsy, as opposed to another child with tuberous sclerosis who did not have those findings. And what they saw was that as they followed those children, they started medications on the children, and those children did not have infantile spasms. And what they saw was that the neurocognitive outcomes were better in children who had medication started even before the onset of seizures than children who had the medication started after the onset of their infantile spasms or seizures. So it makes a huge difference. So that's why a routine EEG could be used as a biomarker for seizure development in this population. Not only just looking at the seizures and the epileptiform discharge and the spikes and the sparks, whatever you want to call it, but also background abnormalities and what the EEG looks like. Does it look mature? Does it look very immature? In newborns and infants with TSC, also correlated with neurodevelopmental comorbidities. So you can make predictions. You can say, okay, I don't see the sparks, so this child may not have seizures, but the EEG background abnormalities and the dysmaturity tell me that there will be more severe neurodevelopmental outcomes in this child as opposed to another child who does not have those findings. So early detection, again, as I mentioned, for identifying of hypsarrhythmia, that's an important thing. And then, of course, you check for blood levels. You do your metabolic testing, because if this is something that we can fix, then you try to fix it, especially when you're looking at infantile spasms. And the benefit of that is prompt initiation of treatment. In this case, it's either medications like vigabatrin or Sabril or hormonal therapy. And then you see what the outcomes are. You would expect to see, ideally, better cognitive and developmental outcomes, but there are certain caveats to that. We'll talk about this in a second. So the biomarkers for early diagnosis and prognosis in infantile spasms, the research again highlights the EEG, the importance of EEG abnormalities, particularly the hypsarrhythmia, again, a very specific pattern that's associated with infantile spasms. That's critical in the diagnosis of infantile spasms. And then you can look at other things like levels of inflammatory markers and chemicals that have been associated with infantile spasms, indicating a potential role for these biomarkers in the diagnosis and monitoring response to treatment. So we can, again, take all of those things and say, okay, we can make the diagnosis, we can hopefully prognosticate, and then start the treatment and see which treatment could work. Genetic testing has identified mutations in certain genes that are linked to infantile spasms, suggesting that genetic biomarkers could aid in diagnosis and provide insights into prognosis. So this basically just shows selected genetic biomarkers in epilepsy and why they are so important. So we can look at all these different um, genes, right? So since we're talking about genes, there's KCNQ23, SCN2A, SCN1A, and all of those genes. And now we know that if we see this, what can we expect? Maybe a good prognosis. You could have uh, normally good prognosis, but in case of an epileptic encephalopathy, you could have poor prognosis. Okay, so with these KCNQ2, 3 genes. So who will have the good one? Who will have the bad one? You know, we'll just have to do the EEGs and other testing to see. Again, same thing with a lot of these genetic mutations. For example, SCN1A is associated with something called Dravet syndrome. So we know that it has poor prognosis and what medications to avoid. So we avoid something called sodium channel blockers, so very specific type of medications. And we learned that over time. It was not just, you know, that you do this and you say, okay, they have SCN1A, we're not going to use it. So you have to look at the type of mutation, and then you say these medications probably would cause more harm than good. So we have to keep those away. So it really helps with multiple things and not just diagnosis. So genetic biomarkers and pharmacodynamics constitute an emerging field with a huge potential. Again, it influences how we're going to pick the treatment, and how are we going to treat, and how are we going to counsel the families of what to expect as the child gets older. Historically, the goal of epilepsy treatments was to reduce seizure frequency. But now what we want to do is we want to see if we can get to epilepsy treatment even before the epilepsy starts, right? So even before it progresses, can we do that? Can we make an improvement in the time to treatment, and hopefully improve the cognitive functions, and improve the neurodevelopmental outcomes. So we'll just have to see, because again, this is something that's starting and we're doing more and more of. So clinical trials need to focus from altering seizures in patients with already refractory disease to allow for the early or even pre-symptomatic treatment of individuals prior to the developing refractory epilepsy. And that's something we saw with the tuberous sclerosis studies. A big question remains, basically, and this is something that we have to keep in mind when we are looking at our patients with CASK, or patients with tuberous sclerosis, or any other DEE, which is whether the uncontrolled seizures or the underlying protein dysfunction primarily drives the cognitive and the neuropsychological dysfunction. And we don't know that. We won't know until and unless we start to look into this in a little more depth, try to modify what's happening, try to control the seizures, and then look at the outcomes. Now, was it the underlying protein dysfunction that led to all of those things downstream, or how much a role the seizures played in the dysfunction later on? So we know that epilepsy can exacerbate behavioral difficulties, but these difficulties often predate the onset of seizures, suggesting that underlying pathophysiology leads to both epilepsy and neurodevelopmental deficits. That's our current understanding. And to obtain higher quality information, we have to consider which features of the developmental epileptic encephalopathies we can measure reliably. And going back to our study, that's why we're looking at multiple things, and we may look at more as we get the charts. An important aspect is looking at the EEG, what we cannot visually see. And that's where we have to really analyze the EEG, not just visually, but using other softwares, using other methods like the spectral power. We're looking at, you know, coherence, and some of the team members will have worked in the past with very complex computer models analyzing EEG, looking at very subtle changes between EEGs, looking at very subtle differences in frequencies between different EEGs. So we will be looking at that also. So analysis of resting state and sleep EEG has been performed for several disorders, including autism, anxiety, depression, and several DEEs, and in normal children as well. So we can employ all that technology and see if we can find even subtle findings between different EEGs. So the conclusion is that biomarkers do play a crucial role in the early detection of epilepsy. They enable timely intervention and personalized treatment, what to use, what not to use, how much to use of a medication. The ongoing research is enhancing biomarker discovery and application, but I think we still need to work a lot more to get to the point where we should be. And research is ongoing, and hopefully we'll get to a point where we know all the crucial biomarkers. We're looking at those in a timely manner and taking action. And that's it. I think sorry, I went over by a few minutes.
You're completely fine. Thank you so much. That was wonderful. I'm going to pass it along to Oksana now, who's going to talk about the epilepsy in CASK study specifically. After that, we will have our Q&A. So as a reminder, if you have any questions, please drop them in the chat box.
Hello, everyone. So in terms of the progress or process of the study, the goal, as Dr. Shahid was talking about, so the goal is to review medical records and try and come up with that connection between what symptoms there are, between what's happening from all the imaging that we can observe, and how we can come up with a model that may be able to predict, early detection and help us with earlier treatment or interventions. So in terms of this particular project, what given that everyone is spaced far away, so we cannot necessarily meet in person. So if you are interested in this particular study, what it involves is once where it basically all the records, there's outlined records. So we're looking to collect information such as medical history, imaging, like EEG and MRIs, and any sort of the related genetic testing that would show specific mutations, and any neurological, any notes that would, either from the primary care physician or neurologist, that would describe the symptoms and the treatments that were that took place to date, and also if any sort of developmental assessments were done, because this kind of will help us tease out the information that we can compile a data set that hopefully will, once analyzed, will show us some sort of patterns to be able to answer that question. Is there something that will help us predict earlier on, whether epilepsy is going to occur and at which stage we anticipate it to occur based on the information we have from historically being able to review and collect. So the goal for this particular study is to, we're aiming to enroll about 30 people, and it is a historical study, so it does not involve any sort of treatments. So we're just looking at what's available in the medical records. So basically, if you were interested, you would reach out to us, and I will drop the contact information in the chat. And from there on, we would set up a time to go through all the questions to properly go through the informed consent process. It would be done remotely via Zoom. And so there's no need for to physically come in to do this. And we would go through every step, every component that would be involved in the study. So we'd probably take about 40 minutes to an hour, depending if there are questions, if we need to discuss any component of the consent form or any component of the study that may be of specific concern to you, a little bit more at length in detail to answer all the questions and make sure that you are comfortable with the requirements of the study and you understand the purpose and the goal and what's involved. And so basically, the enrollment's going to be sort of overlapping or on a rolling basis, because requesting records from the different facilities that that are involved in your or your child's care may take different amounts of time, and so it's understandable that some records may come in sooner than others, and then they would be forwarded to us so that our team can review it and apply those models that we're planning to use and those criteria to be able to score it according to the criteria that were outlined. So again, to go back, which I think I didn't mention, the enrollment criteria. So because I said you or your child. So let me start from that. So the eligibility criteria to be able to participate or to be involved in this style. So in this study, it's all participants would have CASK pathology with and without epilepsy. It would be ages birth to 18. A confirmed diagnosis of a likely pathogenic CASK gene variant, live in United States, and are comfortable taking a survey or speaking in English. And so that's the plan. I know why are we doing we're starting the study within the United States at first, just to get this going, so we can get the initial process and set up this pilot, so we can collect the preliminary information. Later on, we do anticipate and hope to be able to expand it to a worldwide population, because we recognize that there are this is a very the numbers are smaller than some other conditions, and so we want to be able to provide this option for people everywhere. And but for now, it's United States only. Again, I'll share the contact information if you had just had questions and wanted to find out more information, or were interested in enrolling. So once we virtually meet and go through the consenting process, and you don't have any further questions, and from there moving on, the next step would be to do a survey. It's a survey on epilepsy. So if your child has not been diagnosed with epilepsy, a lot of those questions you may skip them, but remember, we're trying to find out, like Dr. Shahid mentioned, in some patients, they haven't had epilepsy yet, but they may have certain markers. So we're collecting information, similar information in both groups, those with and without epilepsy. The survey typically takes about half an hour to 40 minutes, depending on how much information you need to fill in and how complex your child's symptoms are and how complex their treatment may be. And so what exactly would we be looking to collect? Like I mentioned before, it would be genetic reports. So you may provide just a screenshot from that genetic reports describing that specific mutation. So no need to share the entire packet, because I know they could be pretty extensive. Medical records or notes. So that would be your child's neurologist from the initial diagnosis, seizure history, progression of epilepsy, medication history, developmental assessments. If there is no treating neurologist, primary care provider notes, related to that particular, to these categories that we discussed, like to treatment of neurological symptoms or epilepsy-related treatments. And I realize, or we recognize that everyone's situation may be different, because some children may have started out with certain symptoms, but later on, ended up, there's additional diagnosis may have been added. So some of the testing may not have taken place necessarily at the same time or within the same time frame. So if there are any questions in terms of, do I include this or I do not, you can always reach out to us, and we can, on an individual basis, try and come up with what would be the most relevant records that you would need to send in, just so that you don't spend time acquiring additional records if they're not maybe as pertinent to this particular perspective. Okay, so I know in terms of EEGs, we mentioned that we would like to review the EEGs, and specifically for EEGs, the records that we need would be the actual waveforms of the exam rather than the report. Because as Dr. Shahid mentioned, the models we plan to use, we would actually be looking at the signal rather than someone's opinion of what they saw, because opinions may slightly vary, and we want to be able to look at specific numbers in the waveforms. So that's something that would need to be clarified when you're making the requests of the records. And again, if there's any issues or questions, you can reach out to us. We would also like to obtain MRIs if there are any available. So ideally, we would like to get an initial MRI, current or midpoint MRI. And if there was any significant change in terms of when the seizure started at some point, if the MRI was done at that time, perhaps at that point. Please ensure MRI scans are the images rather than the report, and these need to be on a CD. And usually they have like a viewer program on there so that the images could be viewed. And it's for the same reason. The report is great, but it summarizes things. We may need to look at specific slices within the images within that exam, just to be able to pinpoint certain areas which may be small. And so from the clinical perspective versus research perspective, these are different objectives. So something may have not been described in the report as opposed to maybe significant to us when we're looking at the images. How do you obtain the records? You would need to reach out to the treating or imaging facility where those tests were performed and request these records. And as I mentioned, specifically for EEG and MRI, it would need to be the actual either waveforms or images rather than the report. On the medical release, so the medical release, you would have to fill out the medical release form. Usually each facility has their own. If you have any issues and they don't seem to have one, we do have one with our facility that we can share as a template, but typically they will have their own that they would provide. When you do request them, you may specify in the request that this is specifically for CASK study. And again, I will share the information once you're enrolled. The information will be shared with you, because right now there's no need for you to send anything else because technically you're not enrolled. But later on, that information will be shared with you, and you would specify that it's for specific study, who the individual is that it's going to, and which facility will be reviewing these records. Whether the results will be shared. So once we've had a chance to compile the entire data, if there are any results, these are typically shared through publications and different platforms like that. If there's anything specific to each individual, if there's anything clinically significant that is identified that may be related specifically to that particular individual or family. It would not be in terms of diagnoses, but if there was anything identified, a recommendation would be made in terms of who you should reach out to follow up on that specific newly identified issue or whatnot. That's pretty much the general information on the study. So please feel free to add more questions in the chat. I am going to drop the contact info now in the chat. And for now, just give me a sec so I can do that, okay?
Thank you. Okay, so I'm going to unmute Alexis, Dr. Shahid, and Oksana, if you don't mind as well. We had a couple submitted questions previously, and then we did receive quite a few in the chat. So I will Alexis will go through the questions, and then Dr. Shahid and Oksana, whoever you feel is better to answer each, you guys can decide that. So Alexis, I'll hand it over to you.
Hey, sorry if this was already covered. I know we had a question about people wanting to know who will have access to their medical records.
Dr. Shahid, you want me to take this one?
Yes, please.
Okay. All right. So only the delegated study team members will have access to the medical records. And so this would be Dr. Shahid who will be reviewing them, myself, and we have 2 medical residents that are currently, unfortunately, wanted to make it, but were not able to make it because they had an emergency come up. So the 4 of us would basically have access to these records. If there was any change in personnel, that's usually approved by institutional review board. And that committee makes sure that whoever has access to the information is qualified and credentialed to be allowed to do that. So this would typically be only done through the immediate study staff and the staff, and they would have to go through specific qualifications to be able to do that. But at this point, it's the 4 of us that I just mentioned.
And if people had questions or were interested about the progress of the study, is there somewhere where they could go to get more information?
So, Dr. Shahid, are you okay with me answering these? I don't mean to hog all the
Absolutely,
answers.
and I'll see.
So typically there is a clinicaltrials.gov website where the progress of the study is updated regularly, and so you may be able to go on there. It's a publicly available website, and you just put in the keywords, or you can put in the study name, and you'll basically see any updates on the study that are available at the time.
So I know that there's a lot of questions in the chat. Do you all want me to go through those, or can you all see the chat? Would you like to read those and see if you have comments on them?
Let me look through them. Dr. Shahid, there's a question here that I think you may be more suitable to answer. Is there now any treatment for refractory epilepsy for children who got late onset seizures? We tried everything with my daughter since she was 30 months old, and now we are on a combination of
Glucosamide and Epidiolex saw some changes in reduction in the number of seizures. So I mean, that's a difficult thing. That's why most of these DEEs, developmental epileptic encephalopathies, are refractory to treatment, right? So that's what we want to see. Um, you can go through multiple medications, and you just have to find the combination that's the right combination for that child. And that's what we will try to do. So as far as, is there now any treatment for refractory epilepsy? I mean, there are a lot of medications out there, some newer medications, some older medications. I don't know what was already tried in this particular child, but there are medications. But again, is there one medication that you can give and that would take care of the seizures? Unfortunately, no. Even when the medications are designed for a certain syndrome, they may be able to decrease the number of seizures in DEEs, but may not really get rid of them completely.
Okay, there is another question. Is the VNS in this
VNS,
case of
yeah.
late epilepsy and DE an option?
Yeah, I mean, VNS is an interesting option. Number one, it's an invasive test, or invasive procedure, because you have to implant the device and it goes and connects to your vagus nerve in the neck. If you look at the outcomes, it may reduce the seizures by 50% in about 50% of the patients, roughly. Right? Can it help? Sure. Can it take the seizures away completely? No. With that 50%, 50%, it may not take the seizures away. Some patients would say, hey, you know what, this thing is not working at all. We put it in, we swipe the magnet. Others may see some response. So, with DEEs, I think every reasonable thing is an option, and you won't know if it's going to work or not. What about LP352? So LP, I think that's a longboard medication, bexicaserin, I think. So bexicaserin, I think it's still undergoing trials, or maybe approved recently. So we'll just have to see, what the data shows. I think it was approved maybe a month and a half ago, something like that. So still very new, but there are a lot of medications coming out for DEEs, specifically for DEEs, and we will have to see. We have to also consider the side effects, right? So, I mean, all these medications are coming out, but we cannot ignore the side effects. For example, we have a good medication for Dravet syndrome called fenfluramine or Fintepla. But the problem with that is it can cause cardiac valvulopathy. So it can disrupt how the cardiac valves work. So we have to do echocardiograms at regular intervals. So yes, the medications are coming out. This bexicaserin is out or is coming out soon. What are the side effects? How effective it's going to be? I remember when Epidiolex was coming out, people said, this is the best thing. Epidiolex is going to work for everything. Not quite, unfortunately.
Dr.
Will
Shahid, oh, I'm sorry, real quick. It's LP352. Are you talking about the Longboard Pharmaceuticals clinical trial?
longboard? Yeah, I think that's what
Yes.
they're talking about, the 352. I
Yes.
think that's the longboard. Yeah.
So we have been in talks with them, and there is a chance that individuals with CASK could be included in clinical trial.
Okay, good.
We will
Yeah.
find out more in the coming months, but we have been in talks with Longboard. So we don't know at this moment, but we have been, he told me, Alexis and I, we've been in contact with them. So as things come out, we're happy to share that with the community.
Excellent. Thank you. Will the study include children who've not had seizures? Yes, I think Oksana mentioned that. We cannot participate if living in Germany. Oksana?
Well, so Maria, at this point, we are not approved to enroll outside of United States, but like I said, we're hoping that within the next few months to a year, we can expand it to areas outside of United States. So we'll keep everyone posted as things develop, but at this point, it doesn't seem that way. Okay, we plan to start enrollment within the next few weeks. So please feel free to reach out to the email or phone number provided. And then we can set up a time to meet with you, because we are currently approved, so we are able to start enrolling. We would just schedule a time to make sure that there's sufficient amount of time for you to be able to go through that consenting process, so everything can be explained to you in more detail, and give you an opportunity to ask the questions. Yeah, so we basically can start enrolling as of next week. All right, let's see what else is there. Okay, is the study limited to 30 participants, or is that simply minimum number needed? So at this point, it's not limited to 30, where this is our current goal. If we find that we are exceeding the 30 participants, we can expand the number allowed. So we would just apply for an extension. But for now, this is our goal. Are fetal MRIs beneficial or just post-birth? Dr. Shahid?
I would say post-birth, because then we can see the progression, what the MRI looked like when we had the first MRI, and then months later what the MRI looked like, because then we can see when the seizure started in relation to the MRI and what the next MRI looked like. So I think at this time, if we just limit ourselves to postnatal, we can keep the data clean, because otherwise, we'll just have too many things coming in.
Kim, I can, if you don't mind, reaching out to us via email, I can verify about your situation and get back to you, if you don't mind.
Thanks. So yeah, sorry, I know we're on a time crunch. So we had 2 pre-submitted questions. Someone asked, while we want to minimize seizure activity, how do we balance the negative side effects of seizure medications?
So it depends on if the medication has helped or not. And that's always a tough thing. If the seizure medication is working, then what I try to do is I find the right dose. Because sometimes what we do as physicians is we want to control the seizures as quickly as possible. So we may increase the medication up to the highest point. And when we get to the highest point, well, it helps with the seizures, but then you have a lot of side effects also. So what I do is if I get to that point, then I fine-tune the medication. So I may start to decrease it ever so slowly, or try different combinations and see if I can hit a spot where you don't have a lot of side effects or fewer side effects, because side effects may be there, but still have the seizure control. So it really depends on the type of medication you're using and what kind of side effects there are. If a child is not eating at all, then it's unacceptable. But if the child is taking 2 extra naps during the day and not having seizures,
Okay, last question. People with CASK gene disorders have common challenges with not only epilepsy, but also regulating body temperatures, proper swallowing and digestion, and hormone levels. Does dysfunction of the hypothalamus play a role in any or all of these? And does epilepsy cause or play a role in exacerbating these other challenges?
So hypothalamus does play a role in all of those things, like sleep-wake cycles, thirst center, you have your hunger, all of those things. So hypothalamus is a very complex thing along with thalamus, so it has all those connections. So that would play a role. As far as what are the seizures doing? We don't know. We don't know, because again, what came first, right? The seizure or all these other issues, and hopefully we'll try to answer that question. So I don't know, we will look into it and see how successful we are. But one of the things that we will look at.
Thank you.
Thank you.
And
Before we wrap up, oh, I'm sorry. Go ahead, Alexis. Go ahead.
Oh, I just want to say that we're going to have the frequently asked questions on our website. So hopefully that'll help with some of these questions. And also people can reach out to Oksana if they have specific questions about the study, and we'll also have her contact information up. Thank you.
Thank
Well,
you.
if that's it, we appreciate everybody coming. Dr. Shahid and Oksana, thank you two so much. It was very informative. We are extremely excited to get the study up and running. It's been a while that we've been working on it, so we're extremely fortunate to have you guys on our team. If anybody has any questions, feel free to reach out to Project CASK, either Alexis or myself. Hello@Project CASK is our general email, and we can connect with Oksana and Dr. Shahid. And yeah, thank you all very much.
Thank you.
Thank you.
Have a good weekend.
Bye-bye.